Headgears are orthopedic appliances used to intercept skeletal malocclusions in growing children. They can be used to stop maxillary forward and upward growth, distalization of first maxillary molars, and distalization of skeletal maxilla in severe cases. They are ideally indicated in patients with a class 2 malocclusion due to maxillary prognathism, horizontal excess with or without vertical changes, and along with some maxillary anterior protrusions. Components of headgear. There are three types of components: force delivering unit, force generating unit, and anchoring unit. Force delivering unit, face bow and J hook. Force generating unit, elastic source springs connecting face bows and anchoring unit. Anchoring unit, head cap and neck strap. Types of headgears. First one, based upon the direction of force, mesial force, distal force and vertical force. Based on the location of the anchoring unit, cervical pull, occipital pull, reverse pull, combination pull or straight pull, high pull or vertical pull. The significance of headgears. First one, orthopedic effect. Maxilla is connected to cranium and cranium is by number of sutures. These sutures are more oblique and more or less parallel to each other. It allows forward and backward growth of maxilla as the sutures growth. This the force applied on the these sutures constricts the maxilla and reduces its forward and outward growth while maintaining the mandibular growth as normal. Second one, dental effect. Headgears can also cause some dental changes. They are distalization of maxillary molars, extrusion or intrusion of the molars depending upon the line of action of force, intrusion of maxillary anterior teeth when given with the removable plates. Uses of headgears. Growth modulation to correct class 2 malocclusion due to maxillary excess and normal mandible. Then anchorage augmentation, then rotation of molars, then distalization of molars and space membranes. Patients of headgear. Patients obligatory is a necessary factor for the successfulness of headgear therapy. Often patients are not willing for wearing extraoral appliances. This leads to failure of the treatment. Inevitable and unwanted dental changes are also seen along with the skeletal changes. An adequate amount of mandibular growth is required to catch up while maxilla is restrained to correct class 2 malocclusion.